So I'm really happy today to introduce our speaker. Dr. Milena Kaufman is a child and adolescent psychiatrist here at UCSF. She practices at Benny F. Children's Hospital, Oakland, as well as in San Francisco. She is an assistant clinical professor providing clinical care in the UCSF Autism Spectrum Disorder and Neurodevelopmental Disorder Clinic, as well as at Benny F. Children's Hospital, Oakland. She's also a consultant on our CAP line, so you may have had a chance to speak to her in the past. So Dr. Kaufman will be presenting today on autism spectrum disorders. This was a slide deck that was jointly constructed by both herself and Dr. Suzanne Martin-Hertz, who couldn't be here today. So please take it away.
Thank you for that introduction. Welcome, everyone. So our objectives for today will be to discuss what are the core symptoms of autism, and identify what those are, talk about what are the treatments that are available for autism, and then thinking about some of the special considerations when it comes to medication management for this patient population. Okay, next slide, please. So this is, I think, a helpful image that even though when we think about autism spectrum disorder, we kind of have those two first blue bubbles when we think about the core symptoms, the social communication challenges, and then the RRBs, or restricted repetitive behaviors. But there's so many other things that are really involved in the diagnosis that really create challenges when we're thinking about treatment. So we have the comorbidities. So on top, we see some anxiety, mood, sleep disorders that we often see with our patients with autism. We have the ADHD symptoms on the side with hyperactivity and attention challenges. We, of course, can see language disorders and intellectual delays that can play a role in the social communication side. And then from the RRBs, we often can see those lead into restricted and repetitive behaviors that can increase things like aggression and self-injury, and lead to a lot of meltdowns and tantrums when these kids are running into challenges, especially with things like challenges with transitions. And then, of course, we have medical things that we're always thinking about as well. These patients have increased rates of seizures, and thinking about GI disorders that may be playing a role, especially in nonverbal patients that can't tell us, and any immune deficiencies as well. Okay, next slide, please. So getting to those core symptoms. So again, as mentioned, those two major categories, the social communication and then the restricted and repetitive behaviors. So within that first bubble of social communication challenges, we look for challenges in that reciprocity, the back and forth, whether that's, with eye contact, with back and forth conversation. Those are some of the challenges that we're identifying. Difficulties with nonverbal communication, things like lack of gestures, not being able to identify gestures in other people, and of course, difficulty in developing, but also times in maintaining relationships, not just in initiating them. Some patients that are higher functioning can initiate relationships, but often will have a difficult time maintaining them because of their challenges. And then with our RRBs, we look for our repetitive speech and motor mannerisms, also known as our stereotypic behaviors or stimming, which can be things like verbal stims or motor, such as hand flapping or rocking, which are some common ones. The insistence on sameness that we see, are restricted or preferred interests, and of course, sensory sensitivities or sensory seeking behaviors. Next slide, please. Okay, so when we're surveying or when we're thinking about our patients, things that we're looking for from a neurotypical developing side, right? Is there the age appropriate babbling? Are they responding to their name? Again, that back and forth interaction, the social smile, looking up, making, mimicking facial expressions, those kinds of connected moments. The use of pointing and gesturing, bringing things of interest to a parent or a peer if they're a little bit older, and that joint attention, that moment where a child is, pointing or looking at something that they're interested, but then looking back at a parent or looking back at a caretaker, to have that moment be shared, to make sure that that person is seeing what they're seeing and connecting with them in the moment. So when these things aren't present, these are some that can raise some red flags and concerns around ASD. Next slide, please. So those red flags. So if we're missing some of those in the previous slide, and if we have some of these, it can lead us to more concerns around autism. So if a child is having limited use of gestures, not pointing to things, of course, if we're seeing delayed speech, making odd sounds, so often that can be kind of what a parent might report, and that may be the verbal stimming or echolalia, where they may just be repeating a sound or one specific word. Of course, difficulty using eye contact, gesturing, and doing that kind of at the same time, both combining verbal and nonverbal communication. And of course, though, sometimes, with our higher functioning patients, they can make eye contact, but oftentimes when we actually have that conversation with them, that they share, oh, I'm, just looking at your forehead, or I'm, trying to look somewhere else on your face, but it may from a distance look like they're making eye contact. Little or no pretend play or challenges with imitating. So oftentimes, if let's say a child is using toys, or from the outside, it may seem like they are engaging in imaginary play. More close up, when we listen to the quality of the play, it's very repetitive in nature, and we find out maybe they're actually scripting from a TV show and using those characters, as opposed to creating any imaginary play on their own or changing the storyline or narrative. If we see some regression with words that they were using previously that no longer that they're using, and then oftentimes leading a parent or using their hand as a tool because they're not using verbal ways of communicating, and kind of learned that if I lead a parent to what I need, that they can kind of help me in the moment to either get food that I want or a toy. So those are some of the red flags that we can see early on. Next slide, please. Okay, and then some red flags within social interaction. So again, right, not making eye contact right away, not looking people directly, not sharing in those connected moments. Again, that reciprocity, not responding to their name when they're called, not drawing attention to things. So again, that's kind of part of that joint attention, and not having those shared enjoyment moments. Next slide, please. So this is going to be a video that shows some of that challenges with imaginary play. Oh, if we can turn up the volume. Are we able to have the volume up for it? I'm hoping we can play that one more time with the volume.
Jessica, can we try and mute your view and see if that would display the audio?
Oh, you want to talk to Evan? Here you go.
So here you see the behaviorist kind of modeling with the phone, and kind of watching and observing the child and how they're interacting with the toy. And instead of kind of using imaginary play, or mimicking or bringing the phone to the ear, we kind of see more of that repetitive behavior of the child just kind of banging with the phone. Next slide, please. This will be a video. We see some challenges with eye contact and responding when her name is called.
I can't see the video. I don't know if that's the same. Oh, it's showing up.
Do this. Look at me. Very nice. Lydia, look at me, Shauna. Look at me. Look at me. Lydia. Look at Shauna.
So here you see the behaviors really trying to get her attention, trying to have that reciprocity and interaction and connectedness when the child is not able to do so and continuing to look away and not responding. Okay, next slide, please. So then some red flags in our second category, the RRBs. So we're looking for some unusual or odd ways of moving. So that can be the stimming behavior, the motor mannerisms that we may see, like again, the hand flapping or rocking or unusual ways of moving their hands. We can often see rituals develop, kind of the OCD-like behaviors and certain patterns, ways of doing things. Can be really focused on unusual or non-toy items. Sometimes those can be things like the garage opener going up and down, or the blinds, as opposed to toys that are more appropriate for their age. Having more interest in parts of objects or kind of the mechanics. So maybe just the wheel of the car as opposed to the car as a whole. Unusual sensory interests. So sometimes sensory seeking behaviors can be to certain pressures, to certain tactile things, liking how something is touching, maybe rubbing certain materials. And then on the opposite side, sensory sensitivities, which can be to things like loud noises, to lights, things in their environment that may be too overwhelming from a sensory point of view. Thank you. Next slide. This is a helpful video comparing to twins.
Oh, that's right. Here it is. Set. Push. Here, please. Set. Push.
So we see some differences there. They're twin brothers. We see in the first child that social connectedness, right? He's making eye contact with mom. He is engaging verbally. He's mimicking. He's following her within the play, and we see that engagement. Whereas the second brother, we unfortunately don't see that. He's making minimal eye contact with mom. He's nonverbal. He's not making verbal attempts at the car or off like his brother, and you can see kind of his interest is elsewhere, right? He's turned around. He's not wanting to engage in that way with mom. Next slide, please. So in terms of screenings, and if we're kind of having these red flags come up, kind of what is the next step? And so we have the MCHAT, or the modified checklist for autism, that we use, and it's for ages 16 to 30 months. And that is our first step. So if you're seeing these kinds of red flags in primary care, this is a good place to start. And then there's the MCHAT, the revised with the follow-up as well, depending on the scores from the first. Okay, next slide, please. And this is just kind of a helpful guide. So depending on the score, we'll kind of instruct you whether you need to have more concerns to follow up on, or if you need to kind of urgently be making referrals and starting early intervention services. Next slide, please. Okay, so now in terms of what treatment options do we have for these core symptoms of autism? And as you can see, right, the three here are not medications, because when it comes to medications, we don't really think of those as core treatments for a core symptom of autism. What we do work on are the educational programs, so making sure these children are have IEP and the correct accommodations at school in what's known as the least restrictive environment, because we really want them socially engaging and learning, from their neurotypical peers. Behavioral interventions, we'll talk a little more about those on the next slide, and family support. So making sure we're educating families and parents on how to best support their children, because we know, right, the behaviors will only be there for a few hours a week. We really want parents to feel well equipped to handle some of these challenging behaviors and be able to advocate for their child. Next slide, please. So some of the behavioral interventions include ABA, and there's many types of different that are similar to ABA or branches of ABA, like PRT, early Start Denver model is another type of behavioral therapy. Of course, early intervention, which often includes an ABA type therapy, as well as on the other side, the ancillary interventions like speech therapy and OT. We think about modified cognitive behavioral therapy for higher functioning patients. And then, of course, thinking if medications are appropriate. And then for also social skills group are often very important for these groups of patients. Next slide, please. So as I mentioned, right, we don't think about medications right now as a treatment for a core symptom of autism. However, there are comorbidities that we do have treatments for that often can exacerbate or kind of make more apparent certain parts of autism. So for example, if a child also has an anxiety disorder, we may see that be expressed with an increase in their stimming behavior. And we have medications that then can help with the anxiety, and kind of downstream, we may see some improvements in their stereotypic behaviors, but the medication itself is not treating that core symptom of stimming. Next slide, please. So some of the most common comorbidities that we see are anxiety, ADHD, and of course, aggressive behaviors. So for anxiety, this can often stem from sensory sensitivities, from having challenges with transitions, phobias, and of course, right, and you'll hear me repeat this often, right, our first line of intervention will always be those behavioral interventions. But if we are thinking about medications, so we think about SSRIs to treat the anxiety, we can think about alpha agonists, like clonidine and guanfacine, and then using some things off-label like gabapentin or topamax to think about anxiety treatments. ADHD, so we're seeing those same kind of impulsivity or hyperactivity. And again, right, we want to make sure we're getting the right behavioral and academic interventions, but we will use treatments like stimulants, non-stimulants, and then things over the counter like fish oil. Then for irritability and aggression, we really try to separate that into a mild and moderate picture versus a severe to help guide making medication management recommendations. So if the aggression is more of a mild to moderate, our kind of first line would be an alpha agonist like clonidine or guanfacine, which can be helpful for these kind of low frustration tolerance, these kind of behaviors where we see just meltdowns happening really kind of quickly. That can be a helpful group of medications. And of course, most importantly, treating those underlying comorbidities, because the anxiety or ADHD on the surface can often come out and be seen as aggression, especially in our patients. For severe aggression, if we are kind of off the bat having safety concerns for the child significantly harming themselves or others, then we do have that first line group of using a second generation antipsychotic. The two that are FDA approved are Risperdal and Abilify. And oftentimes we may start there for severe aggression. We still do down the line try to switch them away from that group of medications when things are more stable. Okay, next slide, please. So just some special considerations when we are using medications in our patients. kids with autism and adults, they are often much more sensitive to our meds. So my motto is always start low and go slow with titration. If sleep is disrupted, that's always a great place to start because behaviors will always look worse the next day. And so we really want to optimize sleep before we're treating, let's say, this aggression, but really the sleep was the issue in driving the behaviors during the day. For PRN use, we often recommend hydroxyzine and benzodiazepines starting with hydroxyzine. But an important note is that these patients can often have paradoxical or like an opposite response. So I'll often recommend parents to first try a very small dose in a non-urgent setting because that paradoxical response can be more hyperactivity or more aggression. And we don't want them finding that out when they're giving it to their child who's already escalated in the moment. Stimulants, although certainly are very helpful for ADHD symptoms, and we still use them, they can be less helpful for the inattention piece in our patients because there may be other reasons that the child is not paying attention, right? Like they may not be responding to their name, and that may not be because of an ADHD symptom, but because of autism. And then thinking about behavioral interventions all along the way. I'll always frame to parents, medications can be really helpful, but what they're doing is decreasing an intensity of a symptom or of a behavior. It is really just the behavioral therapy that will make a change in the behavior itself. Okay, thank you. Next slide. And then here are just some resources, and you'll have access to all of this, and these can be helpful to share with parents. Next slide, please. And again, just more resources. These are more from a learning perspective for all of you to be able to access. Thank you.
Fantastic. Thank you so much for that great talk. We've got a couple of questions that have come through in the chat. First one really speaks to what seeming lack of family engagement where pediatricians making referrals, parents are contacted, but they don't follow through on those referrals. Maybe there's some disagreeing accounts of what's happening here. Any thoughts on how you might engage with a family that seems reluctant to follow up?
I would say that the best way is to partner and identify what is the parent concern, right? They must be concerned about something because they are coming to you or thinking, did they bring up anything during that visit? Are they concerned about something at school? Are they concerned about something at home? And kind of leading it back to how is that potentially related to a neurodevelopmental disorder and how this screening process can lead to helping with whatever they may have identified as a possible concern.
Fantastic. Thank you so much. There's a question on evidence for fish oil and ADHD and ASD symptoms.
Yeah, so not so much for ASD symptoms, but we do have some evidence. It's not very strong, but we do have some evidence for fish oil within the ADHD symptoms. And so especially for families that are more hesitant to start a medication, I'll always kind of say it's a good place to start. It won't lead to, major improvements, but sometimes it's a helpful place to start with a family and then they can come back and say, okay, yeah, things are not as good, or much or significantly improved, and they may be a little more ready to talk about a medication. But I have families that will continue to use fish oil even once we start a stimulant.
Fantastic. This is a question about a specific child who makes eye contact and interacts with adults, but not with kids, even a newborn sibling, 2-year-old kid, speech delayed. Is this a kid you'd be suspicious of?
Very much so. So it's really much actually a very classic presentation for a patient with autism to be, very engaged with an adult, and parents will say, oh, chit-chatting when we have family friends over, and that, they're talking about subjects that maybe an adult is much more interested in, probably their preferred interest, which may be something mechanical or something that an adult would have more to join in the conversation than a peer. So I would say that is a very strong red flag.
Fantastic. I'm not sure if we'll have time to get to all these, but we'll do our best here. Another question around diagnosing ADHD in a kid with autism. Can you still use Vanderbilt's?
Yes, absolutely. And I'll always say, once autism has been diagnosed, we can go through a more typical evaluation process for the ADHD. And if we do come out with that, I always just explain to parents that, we're going to treat this as the ADHD, but kind of giving that warning that some of those, especially within an attention, may not improve to the same degree as maybe a neurotypical child with the same type of treatment. Because again, there may be these other things in the background, right? That child may be actually engaging in a tick or repetitive behavior quietly, and that's why they're not engaging. They may be not engaging because they're feeling overwhelmed from a sensory perspective, not because they're not able to attune. So absolutely can use a Vanderbilt. And if those are positive, encouraged to treat that the same way, just with letting parents know that we may not see, a 95% improvement, which we, sometimes can get with a neurotypical child with ADHD.
Fantastic. I think we're out of time for questions right now. I think there are a couple of options here. We may be able to follow up by email on some of the more straightforward questions, or for those who have a little time to stay a few minutes after.
Yeah, absolutely. Yeah.
Then we might be able to have a little bit more of a chat on some of these questions and circle back around. But with that, let's go ahead and go on to the next slide, please. We are actually, we could stop sharing at the moment. We're going to transition over to the case discussion part of today's ECHO. Today, we're very lucky to have Dr. Amina Ahmed sharing her case with us with a patient with on the autism spectrum. So Amina, please take it away.
Hi everyone. Can everybody hear me well?
Yes.
Cool. So I have a case for them, and I wanted to focus more on the management part of things, and medications. So it's not so much about a diagnosis, because this case already has a diagnosis. So I want to share a case for a 10-year-old male diagnosed with autism spectrum disorder and gifted intelligence, so he's high functioning on the spectrum. And he was diagnosed pretty young in kindergarten. And at that time, he was started on ABA therapy, started on speech therapy, OT. And then over the years, long story short, so over the years, he's accumulated some other diagnoses, which are ADHD. He's diagnosed with that. He's got Tourette's, he's got anxiety, and is now showing, compulsions and obsessive thoughts. So beginning, I would say, he doesn't have the diagnosis yet, but he's definitely showing signs of OCD. And has extensively done ABA, behavioral therapy, occupational therapy for regulation, sensory issues, feeding difficulties, and is currently in a social skills school. Recently, I also referred him to a cognitive behavior therapist, but he has not started therapy yet. So past medical history is significant, and I just want to mention he has been evaluated by a neurologist as well as a peace developmentalist. He has been part of different research studies. So his diagnosis is well established. He has gotten a lot of therapy, but he continues to struggle with the core symptoms as well as with these new emerging other associated diagnoses that he has. And so he's had constipation. He's been a picky eater in the past. He has seasonal allergies, no surgeries in the past. Birth history was unremarkable. Pregnancy was normal. The birth itself was normal. There was no asphyxia, no trauma, or anything like that. And then there is no, I forgot to put family history, but family history, there's no family history, immediate relatives of having any seizures, any neurodevelopmental problems, or any autism in the family. So he himself is high functioning on the spectrum. I know that's an outdated term, but just to let you know, he's very verbal. He's very, like I said, gifted. He excels in math, loves numbers, and is doing very well as far as academics is concerned, but has a lot of emotional dysregulation, has a hard time focusing, being still. If he's focused on something, he's hyper-focused, he will come into the clinic also. I have to give him something like, one day he was all about tornadoes. He was telling me all the different tornadoes that are there, what are the speeds, what is the one that's passing through Texas, etc. So hyper-focus on things with a lot of data that he presents, but has a hard time being able to cooperate in a group and work on a project from beginning to an end, finish a task. Has a hard time being able to sit, has to work on his own pace, constantly has to move, fidgets a lot, has repetitive behaviors, jumping, clapping hands, is sensory seeking, and has a hard time making friends and keeping relationships. So that's where he is. His current program, he does have ABA at home and was also in school. The ABA kind of was giving one-on-one support in school, almost following him around. And then his goals at school are more so about socialization, participating in the group, staying in the group, And then he also has OT in the past for feeding therapy and sensory regulation, now only for sensory regulation, he uses the OT. And sometimes has been working with OT in school for fine motor writing. He has difficulties with fine motor as well. He has started a social skills group, but mother was telling me that they feel like he has a hard time staying in the group, and it's a challenge. They want him to be able to have a certain amount of attention and ability to stay in the group, participate in the social skills group. So there are concerns like how are we, I don't know if they've really kicked him out of it yet or not, but they see a challenge if he will actually be able to do a social skills group or not. So those are his current therapies. As far as his scales, if I did not do any recent GAD scales or anything on him, but I know that he was, like I said, evaluated by the neurologist and with his development, he gave the scales sometime back. His current medications include melatonin, where he takes 10 milligrams at bedtime. He takes magnesium, 200 milligrams daily. He takes Tenex, 1 milligram daily. And he has failed, this is both for ADHD and behaviors. He's failed a stimulant trial. He tried methylphenidate, but was super agitated on it. So they stopped that. He's also taking leucovorin, 45 milligrams QD, and he's taking fish oil over the counter. Parents have actually in the past taken some advice from integrative medicine, and I think that's where the fish oil and the magnesium was initially started from. So anything else I need to mention? And those are the basic things. So my question to the group is, one, about his medications. Does he need to be on the leucovorin? Do I need to try a different stimulant for him? Because we still don't have very good control of his ADHD, his fidgetiness, as well as his focus, And his second question is, I know we've talked a lot about the behavior therapies, but he's 10 years old. There's a little bit of what do you say, a demand refusal, right? So he does not want to cooperate anymore. At what age does he kind of get out of ABA, and what's the next step? Because he still needs support. So where do we go now from here? And the third question is, I know I've referred him to CBT, but it's not easy to get a CBT therapist, but especially a CBT therapist who is familiar with the child on the spectrum. Is the therapy looking any different? How should I counsel the families? Are there any specific resources for or a sub-therapy of CBT that is specifically for kids on the spectrum? Those would be my questions to the group.
Fantastic. Thank you so much for sharing this really interesting case with a mix of therapies here. I'm thinking that it may be helpful to actually create like a succinct problem list here, just to brainstorm that very quickly. And then we can go into people's thoughts and brainstorm around Dr. Ahmed's questions. So very quickly, do we want to just list the problems here? So ASD, ADHD, I was hearing OCD type behavior, Tourette's, anxiety. Okay. I think those are the main problems that we're addressing here, just as a quick summary. Okay, fantastic. So I'd love to hear from the group. Feel free to go ahead and unmute yourself if you have thoughts on, let's talk about the first question first, about the medication management. Your thoughts on medication management, stimulants, or treatment for his ADHD type symptoms.
He has always tried without Benedict. I see some questions in the chat. Should I just go ahead and answer them?
Okay, sure. Yeah, what's been tried so far for the ADHD? Yes.
So he's tried methylphenidate, small dose, 5 milligrams, was super agitated, and the parents then decided not to continue with that.
So a single stimulant trial. That's an excellent question. Any history of trauma or ACEs?
No. This is a very well-educated family, very involved with the child, has extensively gotten child therapies and gotten involved in research trials and whatnot. So a very supportive family.
Mhm. I'm going to go over to other diagnostic type questions. Lots of strengths being noticed here in the patient. Wondering if there are things happening in the environment triggering the emotional dysregulation, and
Sure,
whether
I
the
can-
family has come up with anything that might help.
Sure, I can mention. So the family is, like I said, very stable, very supportive of the child. On the other hand, there's just one recent stress, but this I think is he's has a baby sister now, an infant. But that's recently. These are long-term symptoms he's had for years. So I don't think that the last few months of having a baby sister has caused a little bit of stress, but not to explain all the other symptoms he has. The family has not come up with anything. The family is, like I said, very accepting. And this is another question actually I had. At what point, there's a lot of talk about neurodiversity and accepting kids on the spectrum as they are rather than changing them all the time. So they are of the belief that they want him to be functional, but they accept him as he is. So they have moved, kind of really construed their house to him. Yeah.
So the other question came in, has he just started middle school?
Yes.
So that's another transition that's been happening. Another question about querying whether to what degree anxiety, OCD type symptoms are actually contributing to the more challenging kind of behaviors in this case.
I don't know, maybe Dr. Kaufman can help me because it's always hard, I find, to tease these things out because these kids are on a cocktail of medications as well as their different diagnoses also feed into each other. How do you tease them apart and what do you do with them? Yeah.
Absolutely. I do welcome our subject matter experts to jump in at this point.
Sure. Maybe I'll start with just the first question. Is that a good place to start to get through all three? So in terms of the stimulant, I just want to verify, was the Ritalin an immediate release or an extended release?
Immediate release.
Okay. So with that, the logo, the kind of that I mentioned of, start low and go slow. One option would certainly be to retrial, but I generally recommend starting at the lowest dose possible. So I have parents cut it in half and actually start at 2.5, irregardless of their age or their size, just because these patients could be more sensitive. So that would be one option is, would he have the same amount of agitation on half of the dose, and would there be any improvement? Or similarly, thinking of switching to the other family and doing that with an Adderall, and similarly cutting it in half to try a 2.5 milligram dose, because it sounds like there's still concerns around active ADHD. And then the other question kind of and thought is in terms of the 10X is thinking about that there's a lot of room to go up on that medication, and seeing if, had there been any improvement on the 1 milligram or any changes, and considering continuing to increase that. We generally, depending on the child size, but generally 4 milligrams is a safe dose to go up to. And oftentimes I'll do that by increasing it by 0.5 at a time. And then if they're on, of course, the extended release, then just 1 milligram at a time. But there's some room there as well. And with guanfacine, you do have some coverage for ADHD symptoms, especially more of the impulsivity and hyperactivity side, a little less for the inattention, but you also have some coverage for some of the anxiety symptoms. But one of the questions that came up, of anxiety as a question mark, and this transition to middle school, it's just a very common time where we see our patients, as you kind of described, and as I'll still kind of refer to as higher functioning, have a much harder time because the social discrepancy and some of the social communication nuances, especially around nonverbal communication, takes a really big leap between elementary school and middle school. And so oftentimes they may have had enough strength to get by in elementary school, especially when a teacher organizes a lot of the social interactions. Whereas now in middle school, they're really left on their own, especially during recess and lunch, and when they're in these kind of group projects. And I don't know if he's in mainstream with a pullout, or if he does some general ed, or what that looks like, because maybe he's, again, to use that word, high functioning enough from a cognitive to be in those classrooms, but socially he may now not be able to keep up, and that may be causing a lot of distress and contributing to that emotion dysregulation. And that's where, to kind of answer the next question about therapy, is really where we want to focus the therapy. So yes, he may not need ABA that's focused more on life skills, or more focused on, when he was younger, developing kind of language and working on things like joint attention. But now we may need to shift it to really working on social skills. So he may need more of a kind of individual social skills therapy that teaches him by modeling and almost really practicing, like, okay, when a peer does this, let's kind of go through some scenarios. What's a way you can respond, or how do you practice, and really doing role play to help these kids gain the confidence and to understand some of these situations. So for example, right, if someone his age steps away from him or moves their body away, right, we know that they may be signifying, okay, we're not interested, we don't want to continue talking about that. For a child with autism, that's a very difficult signal to pick up on, and likely they will not. And that can continue to drive these challenges at school, because why don't kids like me? I don't understand. They're still waiting for that concrete, I don't want to be your friend, and they're not going to get that in middle school. And so it really can affect them emotionally, and then we'll see a lot more emotion dysregulation. So the answer there, again, it certainly is finding the right type of therapy with social skills and a modified CBT that can help with some of the maybe underlying anxiety or low self-esteem that might be coming out, and then medications that are helping to decrease that intensity of the emotion dysregulation that's stemming from that. And we can use the medications like the guanfacine, and I would kind of start there since he's already on it, especially if it's being well tolerated and his blood pressure is okay, and then can kind of reevaluate and think about the SSRI if there's still ongoing anxiety symptoms. The most helpful thing that I'll say, and how I kind of separate, because exactly like you said, on the surface, a lot of it looks the same and it's very hard to parse out. Is this anxiety? Is it ADHD? Which parts of the autism? Is there also a separate OCD diagnosis, or is it more of just those repetitive behaviors that would fall under ASD? Is that I'll teach parents this ABC model: antecedent, behavior, consequence, and I will ask them to log that for a period of time. So the behavior is what we're seeing, the emotion dysregulation, the meltdown. And so in this case, because your patient's verbal, I would have him contribute to it as well, so you can get more information of kind of backtracking. Okay, let's track these episodes of the meltdowns. Mom, dad, what happened, or caretaker, whoever is there, what happened right before that meltdown? Let's kind of follow that through. And then what's happening after the meltdown? Is it reinforcing that behavior? So is he having a meltdown and then he's removed from a classroom? And was that the goal, right? Is he struggling in the classroom and then that meltdown worked because he was sent to the office, or mom or a parent picked him up? We want to make sure we're not reinforcing behaviorally those meltdowns, because then we're kind of teaching, right, the patient that works, and they're going to continue that behavior. So behavior tracking, it can be very helpful in helping us to separate and suss out kind of what's driving it. Was it really loud in the classroom? Are kids talking and yelling, and is that causing a meltdown? Oh, okay, so that might be a sensory sensitivity that's causing the aggression. And so what can we do? Do we need to get headphones on this kid? Do we need to think about making some changes in the classroom for a quiet place? Do we need to think about an SSRI because we can't control the sensory and his anxiety is really high from it? So those things can help us figure out underlying, like, what is causing what we're seeing on the surface.
Thank you so much for that feedback. And so I will talk to the family about increasing the dose, and if the 10x doesn't work, then we can go to trial of stimulants or something like that. But two follow-up questions. One is the social skills. It's always a challenge, right? So most parents, and I'll be honest, I have a kid on the spectrum too, so it's very hard to get a social skills group and a social skills therapist to come to your school or to do it at home. Most of them are therapy-based centers, right? So you are driving that kid to that place and getting this done, and they're coming out there. And they're so impacted to get into. So how do you, and I see that a lot of ABA companies will offer to do social skills. Is that acceptable, or is that not really good or bad therapy? Better to go wait in line, be on a wait list and get to a social skills group? And if you have any other way of the school providing social skills group, because a lot of times, that's the other source, especially in school, if they can provide those things.
Absolutely. So I'll work backwards. So I absolutely think it's important, but no matter what's happening in the home, to create a social skills group, or we sometimes call them like a lunch bunch at school, that sometimes the counselor or school psychologist can lead, because likely this child is not the only child on the spectrum, or not the only child that has social challenges at school. And we want to create school to be a positive place for them. And so this can help to, facilitate that, so that they're able to make friends in a more structured way, because we know if we leave it right on their own, during lunch, it's going to be very challenging to form those friendships. So I will often advocate as part of the IEP to include a social skills group. And sometimes the schools don't have one, and sometimes it's about advocating for it to be formed, and creating like a safe classroom somewhere where the kids can go, where it is facilitated, because they really do need that structure and scaffolding to be able to form and kind of practice, what it means to be a friend and how to create and keep these friendships. So absolutely from the school side. And it helps them to practice those skills from whatever they're learning from the home to be able to do that at school. I think the biggest challenge, and you mentioned it, right, is just, yes, in theory, social skills and individual social skills, we know that's the best. The issue is who can provide that. And that's all, it always comes down to that. My answer is often, it comes down to the individual person teaching. And so, right, there's ABA agencies that I've heard horrible things from many parents. And then I get some, they're like, this is the best thing ever. And it's right. It's because it depends on the behaviorist in your home. And we have no way of being able to monitor that. So I'll often say to parents, spread it as wide as you can, get on every wait list, and use whatever resources you can, because later on you can be more picky. But, I would say sometimes a group is enough for some kids. For other kids, especially if there is more ADHD symptoms on board, they really need it to be individual first, to learn, to kind of first get introduced to social skills before I think they can even get enough out of a social skills group. So in our clinic, we have a social worker on the San Francisco side, and she will sometimes do individual social skills training just with one patient at a time. So of course you can imagine, right, how long the wait time is if we have one person being able to do that. And that's often why it's done in groups, to try to help more kids. But there are social workers, there are some behaviorists that will do individual social skills training. And sometimes that really can be, I think, wildly beneficial. And I think I just wish that there were more opportunities and more people that were trained to provide that for patients that are able to gain a lot of skills from it.
I have two more follow-up questions for you. One is, so, in ABA, there's a lot of research to support parent training now to, do the ABA at home, and they feel like you can impart to the parent to deliver, ABA sort of like therapy at home. Is there equivalent to social skills training? Because there are, I think Maria Garcia Winner also does a course for parent training. Is it worth? But it is expensive. I think it's $2,007. Is it something I should recommend to my patients? That parents can get trained and then start working with their child, or not? Because a lot of this age that they are at 10 or so, most kids don't want to be doing socialization with their parents. They want to do it with somebody else. So that's one question. And the other is, there are a lot of apps out there now, which will also say that, they help with these social skills, they help with things like that. Are there any, would you recommend any or not?
Yes. So then the nationwide kind of most popular social skills group that's been studied and standardized is called PEERS. Most of the time when it's done in that standardized way, it will include parent training. And so oftentimes they'll be separated and the kids will be in kind of one classroom with one person leading, and the parents will be in the next door, learning the kind of aligning skills to be able to practice, because most of the time with the social skills, when it's standardized, there's homework assignments that parents are kind of helping them to follow through, starting with like making a phone call to a friend. And so parents are kind of included and kind of shown how to help scaffold those kinds of social skills. And so that's PEERS, PEERS. And then the second question was apps. I don't know if it counts as an app, but there is a social skills, basically like an online or virtual option that helps to kind of match individuals with autism to pair them into kind of social skills group that may be more helpful. And I'll put a link to that in the chat.
Thank you.
Yeah.
Fantastic. Thanks so much. And maybe I want to point out some of the other wonderful comments that are coming through the chat here. And maybe, John, if you want to unmute and like share your comment here that you made about just the differing reactions to ABA and what came out of this whole neurodiversity talk that you went to.
Right. And so this is relatively new to me, but probably the last 5 years, I've just begun to see pushback from parents that it may be the particular sort of match between the ABA therapist and the patient, but just, having to go through different ABA therapists and then just taking a long time because it's hard to get another ABA therapist. But, on the other hand, some children love their ABA therapists. So I think there's a wide variation, but I think the idea is really, are we trying to force children who see things a little bit differently to adapt to an environment that's kind of rigid, and whether that can be traumatic? And so, for example, a lot of stimming that children with autism do may be a way of self-regulation. And if we take that away from them, that might make things worse. So I guess I'm just sort of in that exploratory phase where I'm just wondering about, whether some of the things that we traditionally have said is not really necessarily the best answers. And I don't know, it's just a question mark there.
Thank you for bringing that up, because it seems like a very a big new kind of avenue of like discourse around clinical care of autism recently. So thank you for bringing that up, Milena. I don't know if you had...
Absolutely. So what I'll share is, ABA has evolved a lot, and absolutely the kind of the way it initially originated was, very rigid. Like, the therapist is saying, today you're going to learn how to say 1, 2, 3, and we're going to sit here at a table, not move until you've said the words, 1, 2, 3 for me. It definitely has evolved. And from ABA, we have a lot more that are naturalistic and child-led, PRT or pivotal response therapy being one of those that really takes the control away from the therapist, and it really is just based on the child's motivation. But I would say in general, most ABA agencies have kind of updated things to be more naturalistic, and I would say that the goal is not to remove those core symptoms of autism. And I completely agree with you. And, when parents come in and say, oh, I'm concerned because my child does XYZ behavior STEM, I always say to them, is it harming your child? And they'll say no, but I'm worried about how it looks or whatnot. And so I'll say, then we don't need to treat that, exactly like you said, because it actually may be self-soothing. It may be helping them. We don't want to treat that unless it's causing harm to the child, right? And in some situations, it is. Some kids may rock really hard where they're actually causing physical harm to themselves, or it becomes a really kind of agitated stim that we treat. But other than that, really the goal of ABA is to, especially in younger patients, help them be able to communicate, because that causes so many of these later downstream concerns, right? Oftentimes aggression, agitation is because the child cannot communicate and cannot make their needs known to the people around them, or being able to tolerate certain kind of daily activities, right? A lot of our kids have sensory sensitivities, don't want to bathe or shower, brush their teeth, that later, right, can lead to some medical concerns. So trying to do small exposures to help them with those kinds of things. Those are still the goals of ABA. And I also, say to parents, right, if that's not happening, then that's a good sign to switch gears and try a different agency or try one of the other branches of ABA that may be more aligned with being child-led.
Thank you so much. I'm sorry, we're at time. So I just want to say, let's switch over the share screen back to the PowerPoint with our QR code. So people can check in for those who need to check in and then go. And those who can continue to stay and continue this incredible conversation, please do stay for a little bit longer so that we can continue some more of the conversation on ASD. So Jessica, if you can go ahead and flash back up the PowerPoint with the QR code so people can check in, and I will also put in I'll put the check-in link into the chat as well. But so those of you who need to go, understood, please do check in before you go. Want to thank Milena Ahmed for sharing this fantastic case with us. Want to thank Dr. Kaufman also for being our subject matter expert for the day. Thank all of you for showing up and sharing your lunch hour with us. Don't forget that our next ECHO will actually be December 7th and not the fourth week of November, because we're running into Thanksgiving there. So December 7th will be our next ECHO. And so, Jessica, are you able to share the, okay, yes, we have it up here. Thank you so much. Okay, so with that, for those who can stay, we can go ahead and continue on this conversation. But I wanted to make sure, Dr. Ahmed, if you had what you needed from the case discussion, if you wanted to maybe share with us maybe 2 or 3 main takeaways that you think are the things that you're taking away from this conversation today?
Sure. I think I would actually like to start. I really like the idea of the ABC, getting a little more data from both the parents as well as from the school about his anxiety and his dysregulation, right? And I personally just working with a family, I know that they would probably be more open to increasing the dose of the guanfacine before they start the stimulants again. But we'll do that. And in the meantime, the social skills group, I think they're trying a social skills group. Maybe the individual social skill therapy would be a better option first. So we'll start, I'd recommend that to them, to start that first. So those would be the key things, I think I look at. And I'm not sure if the regional center also provides social skills group, but I will ask them off to look into that too.
Fantastic. Thank you so much. Okay, so I don't know if people happen to know if the regional center will offer this. I haven't heard of it, but is this something that people are aware of here in this group?
I don't believe they directly, but they should provide resources to be able to direct parents to social skills groups.
Okay. Fantastic. And there are variations on social skills groups, including this group OT from Kids Space in San Francisco. Thank you, John, for sharing that with us. And the online social skills group that Dr. Kaufman just also put into the chat for us, which is great. There was another earlier question that I thought was an interesting one. Does insurance cover social skills training? Because I have heard of many parents paying out of pocket for these.
Yeah, unfortunately, they are generally out of pocket. It depends also on the setting. So most of the times, if it's through an academic center, there can be some option for insurance coverage. But unfortunately, there's only right in this area, that would be us and Stanford. And there's much more options for private social skills. And the wait, they're long everywhere, but they're certainly less in the community. And those are often not covered, unfortunately.
That's really unfortunate. It's something that I think is begging for some advocacy. Because
Absolutely.
Hi, I'm the one that asked the question. Do you mean the privates are not contracted with insurance, or insurance won't cover it if it's delivered by a private?
So most of the time that it's very hard to, so most of the time they don't accept insurance, right? And they'll tell the families to try to get it covered. And oftentimes it will not be covered. Insurances will often decline to cover it.
Thank you.
Okay, wonderful. A question had come up earlier around specific therapy models for self-regulation. So like apart from kind of like the standard like ABA, PRT, social skills, like is there therapy around self-regulation? And what would that be?
There is. I'll put it also in the link. So we actually have a group in our clinic called Regulating Together, and it's kind of combined therapies and kind of modeled to teach self-regulation and emotion skills. So let me put that in the chat here.
Okay. All right. I want to make sure that we got to some of the other questions that were here too, but I want to also open it up for those of you who stuck around. If there are questions that this case discussion or that today's lecture raised up for you, this is a great time to start raising it for the whole group to discuss.
There's one good question in the chat. It's about risperidone, if he's going to be a good candidate for that. I'm not sure what everybody thinks, but typically I stay away from risperidone. I just feel like the side effects are quite a bit. I'm around this severe kind of issues. Most of my nonverbal kids are the ones that we've had, had severe symptoms, severe dysregulation that we've had to use risperidone. I've used risperidone, but for most higher functioning kids, I have not used risperidone. I'd love to hear your thoughts.
Yeah, I feel like this is Eileen, and I think Dr. Kaufman is probably looking up some information. We're really looking at what are the target symptoms. So risperidone and Abilify are most useful for autism-related irritability. And it seems like Dr. Ahmed's case, that a lot of the symptoms may be coming from anxiety, maybe undertreated ADHD. So in these situations, having risperidone or Abilify on the file may not be as helpful. But we definitely have seen other cases when the anxiety and ADHD are well addressed already, and the kids still have a lot of this disruption because they're very sensitive with their sensory. There's just a lot of difficulty with transitions. Those irritability may be better treated with antipsychotics.
Yes, thank you. I was just putting in the information for the Regulating Together group in the chat, and so, like mentioned, I really recommend thinking of first treating those underlying comorbidities to limit the use of the antipsychotics. They certainly have a place in this patient population and can really make a world of a difference when we have safety concerns. But we want to make sure we have first done the least harm. And we know that there are a lot more side effects with these medications that then, down the line can make more challenges for these patients, right? They include blood draws, which are often very challenging for our patients and oftentimes will require, pre-treating with Atarax or a benzo and can cause a lot of aggression in the clinic. So I just encourage to first, try figuring out, is there an underlying comorbidity? Can I treat that and manage that before going to the antipsychotic if there isn't imminent safety concerns?
Fantastic. Thank you for those thoughts. Amy put in a question about babies. So what to do with kids whose parents are worried about autism when very young, like even at like 6 weeks old, not making eye contact, not cooing, or at 6 months where they're quiet, but otherwise developmentally seem okay. Like at what point, like, do we start thinking about autism spectrum disorders?
So we always try to get patients in before around the age of 2 as kind of the end point if we can, so that we have the opportunity for early intervention services. So in general, my answer is always the sooner the better. But again, right, it's not from that one symptom, right, of just a quiet child, but everything else is on track. I think, right, it's really about looking at the whole picture, but also knowing that there may not be the whole picture, right? Because they may be making eye contact or they may have developed speech, but the interaction or the quality of their connectedness or the play, something feels off. So again, it's that balance of not rushing if it's just one thing, but everything else on kind of the trajectory and milestone seems appropriate. But I think, right, if the child is anywhere between 1 and 2, right, and you're picking up things a little bit maybe in one category, a little bit in the other, that may be enough to say, I'm always, upfront with families too, that sometimes come in, for a diagnosis, and I can say, I can't give you a diagnosis right now. These are the symptoms, but we have a lot of strain. So what I'm going to do is I'm going to ask you to please come back in 6 months so we can reevaluate. Please don't disappear because I have these concerns. These may catch up and we may not make a diagnosis in the end, or we may. The other symptoms may become more apparent. And so I think being upfront with parents about that balance is the most crucial, so that we can raise some concerns and some red flags and tell them we want to continue to monitor. If there are enough red flags, then I will give a provisional diagnosis because I want children to get early intervention services, and insurance absolutely will not cover that without a diagnosis of autism. So writing a letter with a provisional diagnosis can actually be very helpful. And what I'll say to families, like, if you come back in 6 months and we don't give the diagnosis, fantastic. But I don't want to lose out on these 6 months without getting some services that will just help your child to ensure their development if this isn't an autism picture. So that's, I think, the most helpful if there's a question mark and it's early on. And then I think I saw Eileen talk about hearing. Absolutely. It's always our first line.
So hearing as the first go-to, but as a general pediatrician, I would actually wonder about what's the dynamic like between the primary caregivers and that young infant. Is there caregiver depression? Is there something else that might be affecting the interaction between the caregiver and this infant that's causing unusual quietness, or causing like maybe some like early soft things? And also, like, if there's a family history or some history in the parents, the caregivers, some experience of the caregiver that's making them especially worried and attuned to this. And so those are some of the things coming to mind for me as well, in addition to the hearing. Now, does at what age will regional center actually start seeing kids like this?
I think it depends on how much push, but regional center will see kids again closer to that two-year mark for an evaluation. Oftentimes, unfortunately, if there aren't enough, regional center will not provide the diagnosis and not cover. But I would, we in our clinic on the San Francisco side, we'll see very young kids. So we've had kids that are not quite 2 yet that are sent in because there's just enough concerns. And again, some of those concerns are not that they're not verbal or not making eye contact. Sometimes it's just really about the quality of their play, the rigidities, and more of the sensory sensitivities that their families noticing.
Fantastic. And there have been very specific questions about what's the lower age range of like screening tools for autism? Like MCHAT will go down to 18 months. Is there anything below that in terms of age?
And please correct me, I think ages and stages starts a little earlier than that, and that can be helpful. I'll put that in the chat one moment.
So the ASQ, just as a general developmental screening questionnaire, is probably the best way to go. Okay. Okay, and yeah, I think many of us share a lot of frustration around the regional center and what they will or won't communicate and what they will or won't do for our families. We could be here all day with the stories. We commiserate. Services on paper or not.
About my case, so the leucovorin, that's the folic acid that he's taking, should he be on it or not? I know it's an investigational kind of drug, but it has shown to have some improvement with kids with speech problems on the spectrum, right? So should he take it? And the other one is vasopressin that's coming up in a lot of trials. And, is that something that in mainstream do you guys use or not?
So there's certainly a few of those. Oxytocin is another one. I would say TBD on exactly how helpful. And, you know, what I'll say to families that feel strongly about it, you know, I'll say, this is what the evidence is so far. A lot of these things are still in trial, like the folinic acid. It's still, we haven't had, you know, good evidence yet for me to say to a family, please take this or start this for your child because it will help. So I'll say to a family, it's emerging, it may be helpful, and then it may not make a difference. If your child is not having side effects from it, you know, feel free to continue, but I cannot make specific right now dosing recommendations. I can tell you what the dose is in the study, and you can model that. But you know, further on out, we have to, you know, wait. We're not there yet for those kinds of medications. The one that I will often use more regularly is NAC and acetylcysteine for this patient group. We use it for skin picking, and it's shown to be a little bit helpful for some repetitive behaviors. And skin picking is kind of one of those repetitive, and can be a little bit helpful for some of the more milder agitation.
And what dose would you use?
Sure. So I'll put the dosing guidelines in here from the study, and they change per month. So I'll put them here in the chat. One moment.
And does NAC help with skin picking from other conditions like ADHD or anxiety?
Yes.
Fantastic. That's good to know.
Yes, and I would sometimes start that before an SSRI, because SSRIs are kind of our main treatment for trichotillomania and other kind of excoriation disorders, but NAC can help in those situations as well.
Okay, this is good to know. Especially in the younger kids where you don't want to do an SSRI.
Yes. I'll also say, aside from thinking of medications, though, oftentimes the most helpful for those is an environmental change. So for example, right, that might mean, you know, wearing a onesie backwards or wearing certain things that cover their arms and don't allow them to pick, especially overnight. I'll often have parents use Elmer's glue on paper, and you basically want to kind of give them a less maladaptive skin picking option, because it may be a sensory activity. It may be really soothing for them to pick, but we don't want them picking at their skin, right? Because of concerns of infection and harm. So, but maybe again, right, like it was mentioned, that may be soothing. So we need to create a way to allow them to engage in that sensory activity in a safe way.
Fantastic. Well, we're at 1:15, so thank you all for staying over.